and hello. Welcome to our instruction course on peripheral ulcerative keratitis, evidence-based management pearls. We'll start with the first talk. The speaker, Dr. Manpreet Kaur, please come on the stage, and Dr. Lumi, also panelist, please. I invite you, sir, to the panel. So first talk will be on PUK Simplified, an algorithmic approach to clinical diagnosis and investigations.
A very good afternoon to all of you. So, peripheral ulcerative keratitis can be relatively challenging to manage, and I'll take you through an algorithmic approach to clinical diagnosis and investigations. At the outset, there are no financial disclosures. So, we all know that peripheral ulcerative keratitis is a form of crescent shaped stromal inflammation which involves the juxtalimbal cornea and is characterized by progressive corneal ulceration and peripheral stromal thinning. What is unique about this entity is that it is commonly associated with autoimmune disorders. So, whenever we see a case of PUK, something systemic, underlying systemic disorder does come into mind. So, pathogenesis, the exact mechanism remains unclear. Both humoral and cell mediated autoimmune processes have been implicated, and reaction to corneal antigen, circulating immune complex deposition, and hypersensitivity reactions to exogenous antigens have been implicated in the pathogenesis of peripheral ulcerative keratitis. So, how exactly does the ulcer occur? The deposition of immune complexes activates the classical pathway of the complement system, leads to chemotaxis of inflammatory cells in the peripheral cornea, which go on to release collagenases and other proteases and cause a destruction of the corneal stroma. So, what's the underlying etiology? So, it's not just a simple autoimmune disorder in all cases, though we do tend to think of rheumatoid or collagen vascular diseases when we see a case of PUK. It can be caused due to local ocular causes and systemic disorders both. For local pathology, infective causes, bacterial, fungal, viral, etc., can be there. Non-infective trauma, local autoimmune, neurological, and lid and adnexa abnormalities. Systemic again can be infective or non-infective. Of non-infective, autoimmune is the most common. Malignancy, dermatological disorders, and inflammatory bowel diseases all have been implicated. So this is just to take you through a detailed overview of the ocular causes, the local pathology, infective agents. So staph, strep, gonococcal, moraxilla, hemophilus, all have been implicated. Viral herpes simplex and zoster, acanthamoeba, and fungal keratitis. When we look at the non-infective local causes, traumatic chemical, thermal, or radiation burns can cause a PUK-like picture. Abnormalities of the lids or lashes such as entropion, ectropion, cicatricial exposure, trichiasis, lag of thalamus can cause a peripheral ulcerative keratitis. Local autoimmune disorders, Murren's ulcer is one of the most common, and allograft reaction. Neurologic causes, neurotrophic keratitis. Systemic, the non-infective causes autoimmune disorders such as rheumatoid arthritis, which may be implicated in around 30 to 40% of cases in which autoimmune disorders are implicated. Wegener's, SLE, PAN, Sjogren's. Dermatological disorders, the cicatricial pemphigoids and the Stevens-Johnson syndrome. IBD and malignancy, of course, we covered. Then infective causes, even systemic infections can lead to a peripheral ulcerative keratitis like picture, tuberculosis being one of the most common, syphilis, gonorrhea, borreliosis and bacillary dysentery, and in viral also, AIDS leading to systemic immunosuppression, hepatitis and varicella zoster. The most common disorders associated with PUK are systemic collagen vascular disorders, of which rheumatoid arthritis accounts for nearly 34% of the non-infectious autoimmune PUK cases. Now, coming to the clinical presentation, symptoms would be like any other ulcer: pain, watering, photophobia, and decreased vision. So, what's essential when you're working up a patient is clinical history, duration and progression of symptom, associated systemic conditions, because you would want to rule out any underlying autoimmune disorders or a systemic immunosuppression, medication history, specifically the immunosuppressive drugs, Key questions are any history of any inflammatory disorders like rheumatoid, any family history of autoimmune diseases. So whenever you're taking a history, there are some things that can help you narrow the differentials at the history point itself. So excruciating pain out of proportion to the severity of ulcer is often a characteristic feature of Moran's ulcer. In acute cases, the diminution of vision that's reported by the patient is often normal or only a mild reduction is there. Acute loss of vision may be a sign of associated corneal perforation. Recurrences are common. So in a history, the patient may give history of recurrent episodes of a similar illness. Past history of trauma or recent surgery may precede an acute attack of peripheral ulcerative keratitis. Now, coming to the systemic symptoms, you have to elicit history pertaining to the systemic autoimmune disorders. They are general constitutional symptoms, then musculoskeletal, skin, gastrointestinal, respiratory, cardiac, and neurologic. All these systems may be involved in the autoimmune disorders. So, a thorough history taking is very, very important because, as you saw the list of differentials, it is very vast and you have to pinpoint the identifying cause, which is not as easy. Signs: peripheral corneal ulceration and thinning, conjunctival hyperemia, involvement of limbus in the form of limbitis and anterior chambers such as iritis, cyclitis may be there, varying degrees of vascularization, perforation may be noted, scleritis. Healing stage is characterized by thinning, vascularization and scarring. Now, PUK associated with systemic autoimmune disease, when you are examining, one is the pain will not be as severe as Moran's ulcer as we saw earlier in the history also. In contrast to Moran's, extension into the sclera may occur. So, scleritis is maybe more associated with underlying systemic disorders and Moran's characteristically has absence of scleritis. There is no separation between the ulcerative process and limbus. So during examination also you will have to keep on ruling out differentials. Infections of course will be associated with suppurative discharge. Clinical signs of systemic autoimmune disorders associated with peripheral ulcerative keratitis. Again, a thorough systemic examination is essential. We saw in history taking that a systemic history is essential. You have to go back to your basics and what you learned in medicine and look for all the musculoskeletal, neurological and dermatological features that are associated with various autoimmune disorders. It may point towards the underlying disease. Now, stepwise approach to investigations. First is the standard screening test, then the tests that are required in specific situations, establishing the etiology at a local ocular level, establishing the etiology at a systemic level, and monitoring the side effects of medications. So we all know that the treatment protocol largely focuses on systemic and local immunosuppression. They form the mainstay of therapy. So you have topical steroids, oral steroids, and a host of immunosuppressive drugs that will be covered in the subsequent talks. So the first step when you are starting with the investigation is to rule out infections, local and systemic both. So superadded infections may be present even in autoimmune related PUK, that you have to remember. So just because you have a PUK related to rheumatoid, you still may have a secondary infection. So the first step when you're performing an examination and going for investigation, do a corneal scraping and conjunctival swab. Gram staining, QH, wet mount, viral PCR should be sent. Then rule out systemic infections and autoimmune disorders. So there is a host of blood panel and other investigations that you have to do. A complete blood count, ESR, LFT, RFT, chest X-ray, urine routine microscopy, ruling out HIV, hepatitis B, HCV and syphilis and a peripheral blood smear. For autoimmune disorders, the initial panel often includes for rheumatoid factor, CRP, anti-CCP, anti-double-stranded DNase and ANA for systemic lupus erythematosus, Pianka, Cianca to rule out vaginous, anti-ROLA for Sjogren's. So these are the basic investigation. Then as you narrow the differentials, if you haven't still identified the underlying cause, you become more specific based on your history and examinations as well. Imaging techniques are a useful adjunct. Confocal microscopy provides high resolution imaging of the cornea and can identify corneal involvement and assess the depth of ulceration. Anterior segment optical coherence tomography again helps in evaluating the extent of corneal thinning and ulceration. These modalities will also be useful to monitor the disease progression, how it's healing, is there going to be an impending perforation. B-scan ultrasonography to rule out both posterior scleritis as well as for a posterior segment evaluation. HRCT to rule out sarcoid or tuberculosis or any malignancy, they can be used. Then we also have to look at the differential diagnosis in conditions that may mimic a peripheral ulcerative keratitis. So marginal keratitis and flectanular keratitis, Tyrion's marginal degeneration and senile furrow degeneration have all been implicated as differentials that may mimic a PUK. So when you come to marginal keratitis and flectanular keratitis, it's less severe and self-limited, begins with an infiltrate, then an epithelial defect, responds rapidly to topical steroids without the need for targeted systemic treatment. There is a clear zone between the infiltrate and limbus, and the associated blepharitis can be seen. Patients generally do not complain of severe pain as is seen with Murez. Tyrion's inflammation and epithelial defects are not seen. Typically painless, does not ulcerate. Demarcation from the central cornea with a gray line begins superiorly, most commonly as fine punctate stromal opacities, and there is a clear zone between the limbus and the infiltrate. Superficial vascularization is seen, and the peripheral thin zone is determined by a white lipid line at its central edge. When you look at the senile furrow degeneration, there is a thinning in the lucid interval between the arcus and limbus in the elderly. The epithelium is intact, there is no infiltrate or inflammation unlike in a PUK. Furrow is shallow, not vascularized with sloping edges, and progression is extremely slow. To conclude and just sum up, history may help you differentiate between different local causes and indicate the underlying systemic diseases. On examination, both ocular and systemic examination are very, very important, and rule out the differentials that may mimic peripheral ulcerative keratitis. Laboratory investigations, one is you have to rule out infection. Second, you have to collaborate with a rheumatologist and run a full blood panel to rule out infections, to do a baseline investigation. You'll also use them to monitor your response to treatment. Any systemic side effects will be monitored by your blood counts, repeated blood counts, and you'll have to run an autoimmune panel as well. Imaging helps establish diagnosis and monitor course, both local imaging and systemic imaging based on a case-to-case basis. So a stepwise approach to PUK may help you to establish a diagnosis and do not do unnecessary investigations and tailor the management to the specific cause. Thank you for a patient hearing.
Thank you so much, Dr. Manpreet. Very nicely covered the entire spectrum. Dr. Yogita, if you can set up your presentation. So Yogita will be covering shifting the paradigm of medical management, also giving you an insight into new modalities and treatment strategies. And as Manpreet nicely summarized the details, that there are so many differential diagnoses and it can be sometimes confusing. And it's a disease which is not very common in a routine clinical practice. It's very important that all ophthalmologists are aware of all the nuances, and they save a lot of time, and sight saving actions can be taken if you the moment you see the patient, you ask for all the investigations straight away and don't start the definitive treatment just blindly. Usually, even though it looks, you can start getting your slides up. Please, Dr. Yogita, slides, get them ready. Usually, it is better to spend a day or two doing the investigations, but of